Hello, everyone. Thank you very much for joining us for this webinar about PBM. Just a reminder that we will meet face-to-face soon in the World Congress of Anaesthesia in Morocco, in Marrakesh, from 15th to 19th of April 2026. And it is a pleasure to be here with all of you to introduce this webinar, Improving Maternal Health, the role of patient blood management, PBM in obstetrics. And today, it is 1st of March, 2025. Just a reminder, has your national society signed the Santa Cruz Declaration, the global PBM consensus? Please, if you haven't signed or if you are not sure, call your national society. Over 100 organizations, including many national societies, have signed it already. We are going to be your co-chairs. Me, Dr. Emilia Guasch, Obstetric Anesthesiology in Quirón Hospital, Fundación Jiménez Díaz, in Madrid, Spain. I'm the current chair of WFSA Obstetric Anesthesia Committee, and Dr. Mauricio Vasco Ramirez. He has been also a WFSA Obstetric Anesthesia Committee chair in the past, and he is anesthesia and intensive care specialist and associate professor in Universidad CES Medellín, Colombia. He is also WFSA ambassador. Let's be sure that we all are at the same page. What is PBM? PBM, patient blood management, is a patient-centered, systematic, evidence-based approach that is centered to improve patient outcomes. How? Managing and preserving patients' own blood while promoting patient safety and empowerment. It is demonstrated at the moment that it improves patients' outcomes, not only mortality, also infection, stroke, and length of stay, and also there are improved key programs indicators about preoperative anemia, pre-transfusion hemoglobin, and one single unit transfusion. This is the moment that everything started in the Santa Cruz Declaration, Santa Cruz, Bolivia, in 2022 during the CLASA Congress. It was a declaration that came out from WFSA and was signed by several national societies, mainly from the area of South America. And after a few years, very few years, in 2024, WFSA celebrates the 100th signing of Santa Cruz Declaration. But why Santa Cruz Declaration is so important? Because there is also an international consensus in PBM importance that comes from the World Health Organization call to action exactly in this topic, to create awareness on iron deficiency, anemia, and other things related with blood management, and create a sense of urgency for healthcare entities to implement these programs. And it has to be done implementing guidelines, specific guidelines, including pregnant patients. And why pregnant patients have to be included and separated? Because they are different and they are a specific group of population, because they have a high prevalence of iron deficiency, because PPH, postpartum hemorrhage, affects millions of women. Postpartum anemia may affect the care of neonates and family, and there is an obvious gender bias because pregnant people are generally considered healthy people, and women's health is important and has not to be cut during crisis, during COVID, wars, etc. Women's health has been in danger. And in high-income countries, there are several problems to access to PBM programs: lack of access to good health care, immigration, no awareness, and in low-middle-income countries, also lack of resources, gap of knowledge, and no access of women to healthcare resources. We have an agenda for today. This brief introduction from me, and the first talk that will come from Professor Mauricio Vasco, optimizing red blood cell mass, the first pillar. The second pillar will be what to do in terms of PBM once postpartum hemorrhage has been declared, second pillar. And the third pillar and the third talk will be from Professor Elizabeth Ogboli-Nwasor about anesthesia perspectives in management postpartum anemia in low and middle-income countries, challenges and strategies. You can ask questions by the question and answer Zoom function. There will be translation. You have to choose your preferred language, and certificates will be sent within 7 business days, and webinar will be recorded and available in YouTube in the next 48 hours. Now it is the moment to welcome our first speaker. Our first speaker is one of the most important obstetric anesthesiologists in our World Federation of Societies of Anesthesia and a real leader in obstetric anesthesia in South America. He's also a nice person. He's a specialist in anesthesia and intensive care, an associate professor in CES Medellin, Colombia University, an ambassador of WFSA. Wherever he goes, he defends WFSA. Mauricio, the floor is yours.
Thank you, Emilia, for your kind presentation. I will share my screen. Please confirm if you can see my slides.
Yes, we can.
Okay, thank you, Rosa. Okay, when we discuss the first pillar of PBM in obstetrics, most of the time we focus on the diagnosis and treatment of iron deficiency and anemia, and that's fine. However, beyond iron deficiency and anemia, there are other critical factors for anesthesiologists within this first pillar that we must consider to maintain blood health. These include the use of prophylactic uterotonics and tranexamic acid, as well as the impact of our intervention on blood loss and transfusion. Let's begin with anemia. Iron deficiency is the most prevalent nutritional deficiency worldwide and accounts for nearly 50% of all anemia cases in women. During pregnancy, routine screening with a full blood count and ferritin levels, if feasible, should be performed at booking and repeated each trimester. Iron deficiency is defined as a ferritin level below 30. Recently, the WHO published an update cutoff points for defining anemia across all populations. As you see here, anemia in pregnancy is defined as hemoglobin level below 11 grams per deciliter in the first and in the third trimester. This guideline also categorizes anemia into moderate and severe levels. The guideline further recommends adjusting the hemoglobin value based on the altitude of the region where the patient resides, as hemoglobin values decrease at altitudes above 500 meters above sea level. Anemia in pregnancy affects both the mother and child, leading to physical, psychological, and neurocognitive consequences. And as you see in this table, it also increased maternal morbidity and mortality. A recent study showed the consequence of anemia in pregnant women and found that the frequency of PPH increased in patients with moderate and severe anemia. Notably, the risk of mortality and morbidity was 7 times higher in cases of severe anemia, emphasizing the importance of preventing and treating anemia during pregnancy and before delivery. Another concern is that in the non-obstetric population, international guidelines recommend a preoperative hemoglobin level of over 13 grams per deciliter for patients undergoing surgery with moderate to high risk of bleeding. However, some studies in obstetric patients show that the hemoglobin level above 13 grams per deciliter is considered elevated and may be associated with increased risk of adverse perinatal outcomes, as you see here. The question remains, and I don't know how this recommendation for higher hemoglobin in non-obstetric patients translate to pregnant patients, especially women prior to cesarean section. From a global level point of view, the WHO guidelines on hemoglobin cutoffs for defining anemia is good, and we need that kind of guidelines for updating prevalence estimates and monitoring progress toward anemia reduction targets. However, relying solely on these numbers can sometimes cause overlook the context of the patient and their specific condition. Therefore, it may be more appropriate to consider a range of normal values tailored to each patient. Additionally, in obstetrics, there are high-risk conditions, as you see here, that either cause anemia or require optimizing red blood cell mass before the end of the pregnancy. Addressing this situation needs collaboration with interprofessional teams in specialized institutions. Considering the point discussed above, it is common to question whether it should be an optimal hemoglobin level to reduce morbidity and mortality due to bleeding before delivery. In my opinion, a hemoglobin range of 11 to 13 is appropriate for a normal pregnancy. However, hemoglobin targets should be individualized in the context of high-risk pregnancies and complex cases, requiring collaborative approach among healthcare professionals and specialists. So, how should anemia be treated? I would like to share two key statements from multidisciplinary groups that care for obstetric patients. The first line of treatment will always be oral elemental iron in the doses listed here. If there is intolerance to oral iron, or if the desired hemoglobin target is not achieved, intravenous iron should be considered. From the perspective of anesthesia, this group of colleagues, including Emilia, who is with us today, has published practical recommendations regarding iron deficiency and anemia. This recommendation emphasizes early screening in testing early, treating with oral, repeating tests through each trimester of pregnancy to assess the response to therapy, and maintain a low threshold for using IV iron in patients who do not respond to or are intolerant to oral iron supplementation. I'd like now to ask the attendees of the webinar, should anesthesiologists be responsible for managing preoperatory anemia in pregnant patients? In which situation do you think our involvement is necessary? And do you believe we have the required peripartum expertise, the competence, the skills to manage it effectively? Please feel free to share your thoughts in the chat. Additionally, I recommend reading this article published at the end of 2024, which explores the pros and cons of this hot topic. Let's move now on uterotonics. Oxytocin is the most effective pharmacological strategy to prevent postpartum bleeding. When administered after delivery, it reduces the bleeding greater than 1 liter by 66%. This approach, known as third-stage care, is an important example of promoting blood health. About the use of monotherapy or combination therapy with uterotonics to prevent PPH, evidence supports that oxytocin or carbetocin monotherapy should be the first lines of treatment. In low-resource settings, oxytocin remains a cost-effective option, while thermostable carbetocin is also an available alternative, as demonstrated by the CHAMPION study. For uterotonic combination, the most effective pairing identified so far is oxytocin combined with ergometrin. However, the interaction between carbetocin and oxytocin are not fully understood, indicating the need for further studies to better clarify this interaction. Anesthesiologists play a crucial role in the administration of prophylactic uterotonics during C-section. For this reason, I recommend implement the international consensus developed by experts in obstetric anesthesia, where the different uterotonic options and doses are shown. This article includes the use of low bolus dose of oxytocin and carbetocin to decrease the risk of hypotension and other adverse effects, like flushing, facial flushing, nausea, and vomiting. The same principle of low bolus dose of oxytocin, known as the rule of three, has been adopted now by the FIGO Society in their guidelines. This approach is vital for reducing those related conflicts among healthcare providers in obstetric service. Now, I will discuss the use of tranexamic acid for PPH prophylaxis. Its use as a therapeutic measure will be addressed by Emilia in the next lecture. I am going to present two studies from 2024 that will help us resolve whether tranexamic acid has a role in the prevention of PPH. Let me know what do you think in the chat before presenting the studies, please. The first one, the Woman 2 study, randomized 15,000 patients with moderate and severe anemia in low and middle countries in order to evaluate the impact of the use of tranexamic acid on the development of PPH. The results show that the risk of clinical PPH was not reduced. And this is probably because the administration of the tranexamic acid in this study was done after clamping the cord, and the fibrinolytic action of this agent needs more time to start. The authors suggest that waiting for the cord clamping to give the tranexamic acid may be too late, and future studies using it early are needed. The second study is a meta-analysis that includes the 5 largest randomized controlled trials on the use of tranexamic acid in obstetrics. One of them, the most well-known of this, is the Woman trial, which used tranexamic for treatment, while the other 4 trials focus on his prophylactic use. 2 of them in vaginal deliveries, TRAP 1 from French and Woman 2, and 2 in cesarean section, TRAP 2, and the US study MFMU. The meta-analysis includes over 50,000 patients, with the primary outcome being massive bleeding and thromboembolic events. Let's take a look at the results. In this meta-analysis, tranexamic acid reduced the risk of massive postpartum bleeding and does not increase the risk of thrombosis. The authors conclude that, based on the results of this meta-analysis, tranexamic acid should be considered for use before a diagnosis of PPH in women at high risk of death. This is why the AIM Woman trial is being conducted in low and middle income countries to evaluate the impact of prophylactic tranexamic acid, as outlined in the schemes here, in patients at high risk of postpartum hemorrhage. We will be closely following the publication of the results. To conclude my presentation, I would like to highlight the studies that show the impact of neuroaxial techniques on the concept of obstetric PBM. This is a big study, population-based study, analyzing over 12 million patients, and the use of neuroaxial analgesia was associated with a reduced need for transfusion after delivery, regardless of if the delivery was vaginal or cesarean section. Possible mechanisms behind this include the continuous monitoring of women receiving neuroaxial analgesia during labor, early detection of blood loss, ongoing support from the anesthesiology. In other words, the use of neuroaxial analgesia during labor may serve as an indicator of high-quality obstetric anesthesia care. In another study, one of the largest today, evaluating the impact of anesthesia techniques on ACRITA, the authors found that ACRITA patients who underwent cesarean section with neuroaxial anesthesia experienced lower levels of intraoperative blood loss and fewer transfusion of packed red blood cells compared to those who received general anesthesia. For conclusions, no take-home message, take-home message. Anemia, early screening and treatment are essential. IV iron should be used in patients intolerant to oral preparation or those who do not respond to oral treatments. Hemoglobin targets should be tailored for a special population. About uterotonics, pharmacotherapy with oxytocin and carbetocin remains the first-line therapy for prevent PPH. Low-dose oxytocin is effective with fewer side effects, as per the rule of threes protocol. Oxytocin and ergometrin is the most effective combination uterotonic therapy. Related to prophylactic tranexamic acid, use of tranexamic acid should be considered for women at high risk of death. We are pending results from the IAM Woman trial. Timing is crucial, and tranexamic acid should be administered before a skin incision in cesarean section and occurring in vaginal deliveries in high-risk patients. And for neuroaxial analgesia anesthesia, these techniques are associated with lower levels of intraoperative blood loss and reduced need for packed red blood cells. Anesthesiologists working in obstetric anesthesia must embrace their role as specialists in perioperative medicine and be responsible for training future colleagues in peripartum medicine. Thank you for your attention, and we will take any question you may have at the end of the lecture.
Thank you very much, Mauricio. It has been a really, really interesting topic and very, very good lecture, and you condensated it in very few minutes. Thank you.
Thank you, Emilia. Okay, Rosa, can you share, please, the Dr. Emilia Guasch CV?
Yes, it's on the screen.
Now I have the pleasure to introduce our chief, Dr. Emilia Guasch. Emilia is based in Madrid, Spain. She is obstetric anesthesiologist, and now she is working in Fundación Jiménez Díaz in Madrid. She is also honorary professor of anesthesia and intensive care at Universidad Autónoma de Madrid in Spain. Emilia is current member of SAIC board as non-officer member, and she is vice president of European Board of Anaesthesia. Main research interests include labor analgesia and anesthesia, postpartum hemorrhage, and obstetric patient safety. Emilia, thank you very much for your leadership, and please share your screen. That's it.
I have to speak about PBM in obstetrics once PPH has been declared, the second pillar. And as we have people from Africa and from South America, it was a good idea to think on a cataract. The Iguazu cataracts and the Victoria Falls may give an idea on what PPH may be. This is the summary and the goals that we will have. To speak briefly about maternal mortality and morbidity, which are the diagnostic challenges, the basics in the management of PPH, the use of drugs and procoagulants, any other measures, and to give a positive message, how to improve. It doesn't matter where we come from. These are two important maps, the World Anesthesiology Workforce Map and the Maternal Mortality Rate Map in 2020. There are many similarities. The higher the maternal mortality, the lower the number of anesthesiologists available. So severe bleeding is a very important topic and very well related with the number of anesthesiologists and the healthcare in our countries. If we go to high-income countries, in high-income countries, maternal mortality is the seventh cause of PPH is the seventh cause of maternal mortality. And when and in which women we found that maternal mortality is higher? In immigrants, people from Asia, and Black people, wherever they come from, they have a higher mortality rate, and they have a higher mortality rate the most deprived group of people. So it's not a question of country, it's a question also of the low resources. If we go to a low and middle income country, it could be India or it could be any other one. I chose India because it has a huge population. We can see a different perspective. Despite the regional differences in India, 47% of maternal deaths are because of PPH, of postpartum hemorrhage, and it is very important and preventable cause of death. In general, 1 to 2% of deliveries are affected by PPH in a higher or lower degree. It is decreasing its incidence in low and middle income countries because of better care and facilities. These are the good news. And we are increasing the number of deaths in high-income countries and the incidence, not only deaths, the incidence of PPH because of the socio-demographic changes that have happened during the last decades in Europe and the USA and in the high-income countries in general. But it's not only a question of mortality, it's also a question of morbidity. And the most important thing about morbidity is cardiac arrest. Cardiac arrest has been investigated in the UK in the NAP7 study, And the major cause, the main cause of a cardiac arrest in pregnant women is major hemorrhage. So it is not a question of dying of PPH, it's severe morbidity. And one of the most important things is recognition. Sometimes we are called, we are phoned, and we arrive to a scenario like this. And we have the impression that too little is done too late, and that there is a delay in the diagnosis and especially in treatment. We know that bleeding is normal after a delivery, vaginal delivery or cesarean delivery, but it is not normal, this scenario, and we have to be aware of this kind of things and to know which PPH will progress to massive, what is not easy. About the definitions, what is a PPH? There is a huge number of definitions. If we go to one or another guideline, we have slight differences in what is a PPH. If we try to define based on blood volume loss, we are under the risk of underestimation because it depends on several questions like anemia, as it has been highlighted a few minutes before, or definitions based on pathophysiological changes, what is under the risk that the PPH is unmasked because the pregnant women that are bleeding are normally healthy and fit, or definitions based on what we have had to do. That's not a definition, that's a description of what happened. So it has been advocated a new definition that it's a cumulative blood loss equal or greater than 1 liter or any blood loss associated with clinical or laboratory signs of shock tissue hypoperfusion in the first 24 hours. The risk recognition is also important. We have to be prepared in high-risk cases, and we have to know which is a high risk. But let's remind that up to 50% of cases of PPH happen in women who don't have any risk factor. So let's try to be prepared at any case. In the question of causes of PPH, most of PPH respond to the T of atony. Is the rule of 4 T's. The T of atony may be responsible up to 70% or up to 75% of PPH. It is not much related with the incidence of coagulopathy unless the PPH is massive due to uterine atony. Tissue, trauma, and especially thrombin causes are much more related with the early appearance of coagulopathy, what it makes even more dangerous, the PPH, and can lead to a massive situation of more than 2.5 liters when we arrive to this scenario. It is important to quantify. It is nice to have a sweets box and to calculate or estimate how many sweets we have, but it's even better to measure and to weight how much is the bleeding, and we have to use gravimetry. Remember that 1 gram is equal to 1 milliliter of blood. So weigh the drapes. How sick is the patient? It depends on the patient. Not all the patients tolerate bleeding on the same way, and we need objective tools. And one of the objective tools is shock index. It is a simple index in our hands, wherever we are, that it's heart rate after systolic blood pressure. It has been used in other scenarios and also in PPH scenario. And if we have heart rate over 100, shock index over 1, and estimated blood loss over 1, we know that our patient needs urgent attention and treatment and blood or fluid resuscitation. It is also highlighted in this expert opinion paper. If we have a patient tachycardic, pale, hypotensive, with critical blood gas analysis and some other parameters, this patient needs close and active monitoring and treatment. The goals when we are in front of a PPH is hypovolemic correction, coagulopathy treatment, especially prevention if we can, and to reach uterine contraction, but with protocols. This is not a question of eminence, it's a question of evidence. So it is good to have protocols in every department and adapt the protocols that exist in literature to your own peculiarities. Fluid resuscitation, we have to start as soon as possible to avoid cell apoptosis and tissue damage. We have to improve cardiac output to maintain global blood flow. And we don't know which is the exact amount because we don't have a special and specific model for PPH. And which kind of fluids? Crystalloids, not too much saline, and avoid too much gelatin. In terms of getting our patient better, it is important to avoid things going worse. So maintain temperature over 34, pH over 7.2, and calcium concentration over 0.9 millimoles per liter. Normocalcemia, normothermia, and the good pH to avoid lethal triads. And in terms of perfusion, avoid acidosis, avoid excessive difference between central venous PCO2 and PaCO2, and the sinks of the arrangement includes hypothermia, acidosis, hypocalcemia, platelet count below 50,000, the arrangement of coagulation parameters, and fibrinogen level below 2 grams per liter. All of these numbers tend to go to normal when we are doing a good fluid resuscitation. And include communication with blood bank. Wherever you are, you may have blood supply. So communicate with your blood bank. If you need blood now, blood in 30 minutes, or blood up to 1 hour, communicate with them for the moment that you need, they have to give you. Mauricio has talked about uterotonics. The Cochrane Library says to us that active management of third period of labor is important, and if we give oxytocics, it is much better than non-giving oxytocics. Whatever you give, it is better than nothing. And what about hemostatic drugs? Mauricio has also mentioned the woman trial. The woman trial marks a before and after in PPH, and it was set from 2017 that tranexamic acid administration between the first and third hour, that means as soon as possible, reduces death rate because of PPH in 1/3. That it's an enormous differences and less laparotomies, and even better when early administration. What does the Cochrane Library says? Give tranexamic acid as soon as possible, as early as possible, and in the meta-analysis, there are no differences when we give it prophylactically, despite the data that come from TRAP trial that gives promising results in prevention when you use tranexamic acid. But at the moment, the meta-analysis included very diverse studies and couldn't find a very important difference. Use viscoelastic tests whenever it is possible and available for you. Use laboratory tests, whatever you have in your hand. If you don't, or if it's faster for you, use blood gases that will give you a very good orientation on where you are, or if you're going worse or better. And if you have nothing, go for empiric. And in case of empiric, a massive PPH, you need a massive transfusion protocol, especially in cases where the cause of PPH is related with the T of thrombin or the T of tissue. Use empiric massive transfusion protocols. with a ratio that it's recommended 4-4-1. Let me insist in basic preconditions: temperature around normal, pH over 7.2, not with bicarbonate, with fluid resuscitation and with active management of p-PH. Calcium, normocalcemia, tranexamic acid in early stages of p-PH, diagnostic point of care whenever it's possible, and if not, blood gas analysis, laboratory tests, transfusion, and initiate transfusion protocols, massive transfusion protocol if we have a massive p-PH, and transfuse patients. Don't transfuse numbers, but have some targets. Hemoglobin between 7 and 9, meanwhile, or at the moment that we have an active bleeding, platelets over 75, fibrinogen over 2 grams per liter, and if you have point of care, be guided by FIV-TEM, X-TEM, and prolongation of PT and APTT. And if you have the possibility to have factor 13 quantification over 60%, and only in refractory bleeding, consider 7A factor if it's available. But what happens if it's a really massive hemorrhage? During severe ongoing bleeding, hemostasis should include early tranexamic acid that can be repeated after the first dose, and continuous infusion is not recommended in p-PH, and use massive protocols with a ratio 4-4-1 between red blood cells, plasma, and platelets, and give extra fibrinogen despite these proportions, because fibrinogen is the first factor to go down in this massive p-PH, and especially in p-PH related with the T of thrombin and the T of tissue. There is an uncommon entity that it's called acute obstetric coagulopathy. It's the same coagulopathy that happens in amniotic fluid embolism. It happens because of hyperfibrinolysis and dysfibrinogenemia. And we have to be aware that the quantification of plasmatic factors is lower as much as it advances the p-PH. It is lower when the bleeding reaches 3 liters, and they remained almost normal up to 2 liters. And one of the factors that go down faster is fibrinogen. There is a linear decrease. There are very few women with early acute obstetric coagulopathy, but it happens. It happens in these causes of hemorrhage, and they have to be managed for sure with tranexamic plus extra fibrinogen. It is uncertain that we have to administer factor 13, but factor 13 is closely related to the number of platelets, and it is not clear that the administration of fresh frozen plasma could be beneficial for these women. In the future, we will have to know in these entities that it's massive hemorrhage or hemorrhage related to tissue or thrombin, how and when to replace fibrinogen and the optimal source of fibrinogen. Calcium has to be maintained in the normal range. It is a key factor for coagulation and for uterine contraction. Hypocalcemia is associated with severe p-PH because uterine contraction is also impaired despite the impairment of coagulation. Fibrinogen and calcium are independently associated with p-PH, and both of them are parameters for high risk of p-PH identification. There are promising results in its administration depending on the cause of p-PH. So the recommendation is to keep calcium in normal ranges. Surgical treatment is another tool that we have in our hands, and surgical treatment has changed along the last decades because of the socio-demographic changes that we have described a few minutes ago. And among these new treatments is the embolization, the radiological, prophylactic, or therapeutic embolization, and the REVOA, the resuscitation endovascular intra-aortic balloon. The intra-aortic balloon is placed on in the area 3 of aorta. It means infrarenal, to stop the perfusion of all the inferior part of the body. And it allows to manage accreta cases without any bleeding. And after the clamp of the or the deflating of the balloon, the perfusion and circulation is restored. It's not free of potential complications, but it may be a life-saving procedure, especially if you have previously diagnosed the accreta case. In the interventional radiology, preventive interventional radiology may be right for maternity patients, and it has to be perfectly balanced risks and benefits. And the role of therapeutic interventional radiology, it is still unknown, but I have to say that we have used it widely in our hospital with a lot of successful cases and very low rate of complications. Cell savers. Cell savers are important in this setting, especially if we don't have the possibility to transfuse this kind of patients. The safety and effectiveness of cell savers has been determined because of the results of Salvo trial. Salvo trial was performed in the UK several years ago in 26 hospitals, and they found that no amniotic fluid embolism cases were documented, that the transfusion rate decreased importantly, a lot, and the isoimmunization rate was significantly higher. The inconvenient is the cost, and it's not cost effective as a routine. You have to give additional prophylaxis anti-D when it's indicated, and it can be an alternative in Jehovah's Witness. It has to be used, it may be used in when we have cases with anticipated blood volume loss, and always following the guidelines for intraoperative cell salvage. In those patients in whom transfusion, in what transfusion is not an option, you should have a local procedural guideline, especially for people who are not used to manage the cell salvage machine, for them to be familiar and proficient with the technique and give additional RHD prophylaxis. This slide has been also showed by Mauricio about patient blood management in pregnancy, but we have gone slightly to the right, and it is a different patient blood management because we have the 3 pillars, but we have the 3 periods: pregnancy, delivery, and postpartum. And we need a rational and restrictive use of allogenic blood products. Blood transfusion is like an organ transplant. So be careful with organ transplants. Let me try to start summarizing with some emotive words. Emotive words that come from a randomized trial on early detection and treatment of postpartum hemorrhage performed in Africa in 80 hospitals from Kenya, Nigeria, South Africa, and Tanzania, with more than 200,000 women after vaginal delivery, and they recommended early detection and trigger criteria for detection of PPH, massage of uterus, oxytocic drugs, tranexamic acid as soon as possible, start with IV fluids as soon as possible, and a second IV access, and examination and early escalation of treatment to avoid unnecessary delays. The take-home messages is that this is a business for sure of multidisciplinary approach, preventive possible, clear definitions and quantification for clear identification. Start with basics, avoid lethal triad, hypothermia, acidosis, and dilution. Contact blood bank to be sure that you will have if you need. Evaluate severity of the patients and transfuse patients, not numbers. Have protocols. Monitoring human and technical. It is not a question of putting and switching on a monitor. Human monitoring is important. Use tranexamic, fibrinogen, and procoagulants when needed. Thank you very much, and I hope to see you all in Morocco next year. Mauricio, will you introduce?
Yeah, if you like.
Elizabeth, please.
Yes, of course. Elizabeth, can you hear us? Okay.
Yes.
Yeah, okay.
Yes.
It's my pleasure to present Professor Elizabeth Onuwa Ogboli-Nwasor. She is a professor and chief consultant, Department of Anaesthesia, Faculty of Clinical Science, College of Medical Science, Ahmadu Bello University. She is the immediately past president of the Nigerian Society of Anaesthesia during period from 2018 from 2022. She's formerly the president of the EAPS Cancer Pain Group and currently the president of the EAPS Pain Education Committee. She is also the president of the Society of Obstetric Anaesthesia of Nigeria and vice president of the Sharia Palliative Care Association. Elizabeth was a member of the Education Committee of WFSA and current member of the Pain Management Committee, a member of the Council of the WFSA. Elizabeth, thank you so much for all your support. Welcome, and please share your presentation.
Thank you so much, Mauricio, for the kind introduction. So, can you see my slides?
Yes.
Thank you. Thank you so much, Emilia. And because of the beautiful presentation from Mauricio and Emilia, I will just be talking about the obstetric perspectives, obstetric anesthesia perspective in managing postpartum anemia in LMICs. I will be talking about the challenges and strategies. Yeah, so we'll just go straight into it. Sorry. Okay, so I'll be talking on these different platforms: postpartum anemia, anesthesia management approach, challenges in low resource settings, strategies for improvement, and our role as the obstetric anesthesia teams. And of course, I'll mention some future directions. Yeah, so about postpartum anemia in LMICs, I will just mention briefly because Emilia has talked a lot about this. We know, of course, that the postpartum anemia is highly prevalent in LMICs, and it causes increased maternal morbidity and mortality. And also it has an increased economic burden on the healthcare systems because people tend to spend more money because of the increased complications. And of course, a lot of this money is out-of-pocket expenses. So what are the causes and factors of postpartum anemia? I'll just run through it because, of course, the two previous speakers have done justice to it. We know a lot about inadequate iron intake because of poor iron sources. This is common in areas where there is poor diet and malnutrition and poverty. Also, there might be issues with malabsorption and lack of adequate supplementation. Then there are issues with postpartum bleeding. We have talked about uterine atony and how to prevent it, placental abnormalities, and of course, problems with birth trauma. And then we have very prevalent issues with infection in LMICs. This is very common to have pregnant women with malaria, hookworm infestation, and other parasitic infections. So what do we need to do? Of course, we need to have diagnosis and assessment. And just like we said, it's a common issue. It's important to do screening from the pre-operative period or during the pregnancy from the antenatal clinic. And so it's important to have routine HB testing during prepartum and postpartum visits. We've talked about the risk factors like malnutrition and lack of access to supplements. This might also be a problem with poverty and also poor health-seeking behavior, because some of the patients may not go to hospital on time, so they are not able to access even the antenatal care facilities. So what is our management approach as anesthesia teams? Of course, we know our routine is to do a proper and comprehensive preoperative evaluation, take a good history, obtain detailed medical and surgery history. We need to assess the airway and all the systems, but with particular attention to the cardiovascular system and the respiratory status of the patient. Of course, we need to order appropriate investigations based on the patient condition, but like the basic minimum which we do is always to have a full blood count and differentials, and also to do urine testing and blood culture. And a blood grouping and cross-matching. So what are the intraoperative considerations? Emilia has talked in detail, and also Mauricio mentioned issues about anesthetic technique. This is very important. In our practice, we tend to do more of spinals and some combined spinal and epidurals. Of course, there may be some cases that are not suitable for spinals or any regional technique, in which case we have to do general anesthesia, but these are fewer, becoming fewer nowadays. We have more spinals. So monitoring is very important to optimize and ensure patient safety. Even with limited resources, we insist that the patient should have the minimum acceptable monitoring, which includes monitoring of the vitals, especially pulse oximetry. Fluid management is very vital. Previous speakers have spoken in detail about this, and yes, we are to be careful with our colloids. We can give adequate crystalloids like Hartmann's solution, that is ring gas lactate or normal saline. Sometimes we may need to give dextrose saline. Postoperative care is very important. Monitoring has to be continuous, and we have to always take care to be sure that every aspect of the patient's status is adequately monitored. Pain management is important. Multimodal analgesia is important, and we need to minimize opioid use. Well, a lot of times, even the opioids are not very much accessible, but the background thing is to have, when you have a regional technique, you tend to spare the use of opioids. Active patient blood management is important. The third pillar is always important, that we make sure we optimize the patient's blood status and physiological reserve in relation to anemia. Of course, this has to start from during the pregnancy or prepartum period. Respiratory support is important to provide supplemental oxygen and respiration assistance as needed. Each case has to be taken on a case-by-case basis. So patients are treated as what they will require. So what are the challenges that we tend to face? So one of the big challenges is the lack of access to blood products because there's limited blood bank services in many of the hospitals to provide adequate supply chain for blood products. Sometimes also there might not be facilities to provide fractions of blood products. So a lot of time there is wastage of blood because whole blood is given when platelet concentrate can be useful or fresh frozen plasma can be useful, or packed red blood cells may be indicated. You find us giving fresh blood because the facilities to give the blood fractions are sometimes not available in most of the peripheral hospitals. And sometimes there might be delay in the blood availability because of the time needed, the logistics, maybe the blood bank is far away and the time needed to procure the blood and get it available to the patient. There might be some delay in obtaining the necessary blood products. Also, there might be inadequate screening. Some hospitals may not have adequate facilities for a complete screening of the blood to do a full blood grouping and cross-matching and screening for different transmitted infections like HIV, hepatitis C, hepatitis B. But we still try to ensure that the basic minimum is to do HIV screening and hepatitis B virus screening on the blood that we transfuse. So talking more about the infrastructure and supply chain limitations, there might be even shortage of basic anesthesia machines, monitors, and medications. There might be shortage of the drugs, the medications that we need, because sometimes tranexamic acid is not available. Sometimes some of the oxytocics may not even be available, but as much as possible, we try always to provide wherever there are services for delivery, oxytocin is available. Carbetocin might be more difficult to procure, but we usually try to have oxytocin. So those are some of the issues. Another issue is the problem of unreliable power supply. There may be power outages which can disrupt patient care and prevent timely procedures. But as much as possible, most hospitals are encouraged to provide generator sets that can use petrol or diesel to run it. And nowadays, there's increasing use of solar power. So we tend to use solar panels and equipment, a lot of equipment that are powered with the solar system are in use. And so that can mitigate this problem. You have talked about the problem of supply of blood and some of the medical supplies, but we tend to have other ways to go about it. Like in Nigeria, we have the National Blood Transfusion Service, and we do have the places close by to major hospitals that you can actually request for the blood you need, and it will be provided within a record time. So there are other issues we have, like training and skill gaps. In LMICs, there might be inadequate training programs. and there is limited access to specialized education and hands-on experience. However, nowadays we are mounting a lot of training, we are increasing capacity, we're doing a lot of online training on webinars. Nigerian Society of Anaesthetists, specifically, we are doing weekly webinars for our residents and also for all practitioners and anesthesia providers. Shortage of qualified personnel. This is a global problem, but it is more there in the low and middle income countries. We have insufficient number of anesthesia providers, physician anesthetists are in short supply, and sometimes there might not be obstetricians available or people skilled in obstetric anesthesia. However, we tend to have nurse anesthetists to meet up in the hard to reach areas, and some hospitals in some parts of Africa have clinical officers who are trained and are able to give some of these very important anesthesia care. And then there is a problem of outdated clinical practices. Some people have not adopted the contemporary obstetric anesthesia techniques. However, we are also mitigating this by training and more training. And this has reduced to a great deal. Yeah, so what are the strategies that we have for improvement? I've mentioned some of them as I've been talking, and there are more that we can do. Things to do with optimizing blood conservation is very important. We are training, there are more ongoing training of hematologists and providing hematology services so that we can get blood and get adequate blood fractions to be able to use at the right time. And of course, we are promoting transfusion alternative. We are using cell salvage, and we are also using blood recycling techniques. The EAT-set, that's the emergency auto-transfusion set, was developed or devised by a Nigerian anesthetist in the 1990s and has been made into a patent and it is in use. And we also enhance coagulation management. We implement protocols for proactive coagulation support. And tranexamic acid is becoming increasingly available, so we use it to reduce bleeding intraoperatively. Also, we improve management and we streamline the use of blood products and also ordering storage processes. So this has reduced some of the bottlenecks that we tend to observe. So I've talked about improving blood bank infrastructure, but still there needs to be improved funding so that we can invest in modern blood storage and testing facilities. We have strengthened blood donor recruitment. We do donation drives for voluntary blood donation because that is still date one of the highest ways of getting blood for our patients. So we implement targeted campaigns to increase voluntary blood donations. We go to schools and colleges, and really we tend to recruit a lot of donors in this way. And we also enhance safety protocols. We implement robust control measures through training and retraining of staff. So what is our role as obstetric anesthesia teams? We are doing more, we tend to do more, and we are encouraging multidisciplinary collaboration. Nowadays, we talk about interdisciplinary collaboration, where all the disciplines are working together as a team rather than in silos. So we have obstetricians, anesthesiologists, nurses, hematologists, and all the healthcare providers working together to provide comprehensive obstetric anesthesia services. And also we share expertise. So we leverage on our diverse clinical knowledge to address complex obstetric analgesia and anesthesia challenges. And we hold talks, we hold clinical meetings that are interprofessional. and interdisciplinary, and we share ideas. Also, we do continuous professional development, and this is one of the measures that WFSA is doing to have collaborative approach towards patient care. So we review cases to identify areas for process and quality enhancement. So whenever we have morbidity, we can do a morbidity review or a mortality review and discuss the issues to prevent future occurrences of negative events. Continuous quality improvement is always encouraged because we monitor our maternal outcomes, we track and analyze maternal morbidity and mortality data to identify the areas for improvement. And of course, we are implementing evidence-based practices and adopting standardized protocols to enhance patient safety and care. So capacity building is ongoing, and we are developing training programs. We started the Obstetric Anaesthesia Fellowship in Nigeria, and we have had several anesthetists from all across Africa coming together and coming to spend 6 months to have more skill and build capacity in obstetric anesthesia. And we're also doing mentorship programs. We're preparing and training, and of course, continuing education. We are organizing workshop conferences to show up our practices and to improve on what we are doing. There are future directions that we need to embrace. Innovative technology is very important, like telemedicine. We're expanding access to remote obstetric anesthesia expertise. There is this program in Nigeria where midwives are given smartphones, and this is helping them to communicate with specialists in the bigger centers and also to refer patients and make timely intervention as soon as possible. Use of points of care ultrasound is very important. It has improved anesthesia administration and patient monitoring. And also we have enhancing training and guidance for all our anesthesia providers. In future, what are the things we need to do? There are research priorities. We need to explore novel anesthesia delivery methods for resource-limited settings and capacity buildings. We still have to do more to upskill local healthcare providers, train more midwives, train more anesthesia providers and more obstetric providers to be able to do more for our teeming population of patients. Of course, technological advancements are always important, so investigating costs of medical devices in low resource environments is very important, but all this needs a lot of funding for research, funding for technology, funding for telemedicine. There are so many things that we can do and we are doing, and we still need to do more, but the important thing is that we need to embrace the pillars, all the 3 pillars of patient blood management, and we need to upskill all the facilities and services that are providing for our patients to improve patient safety and outcomes. Thank you very much for your time, and I'll be willing to take your questions and comments. Thank you.
Mauricio?
Hi, Emilia.
Thank you very much, Elizabeth. Thank you. Thank you. It's been a very good lecture. And Mauricio?
Yes, Emilia, we have maybe 5 minutes or 10 minutes to take a couple of questions. There is one question about shock index. It is possible to give more data about shock index, Emilia?
Yes, I tried to answer during your talks to the question that have been raised in the chat, and one of them was about shock index. Shock index is heart rate after systolic blood pressure, and if shock index is over 1, you need urgent and emergency attention to your patients. as if the patient is over 100 and the bleeding is over 1 liter, the rule of ones. If shock index is between 0.9 and 0.7, your patient deserves some close surveillance, but not immediate attention. And if the shock index is below 0.7, your patient is fine from this point of view.
Okay, great. Elizabeth, this is a question for you.
Okay.
Yeah, it's about if you have experience with uterotonics, different to oxytocin, misoprostol or thermostable carbetocin.
Thank you very much for these important questions. Yes, I do have experience with oxytocin and then carbetocin and also misoprostol. But generally, we tend to use more of oxytocin because of the cost and safety profile. However, where we do have very difficult and intractable bleeding that where the uterus is not contracting adequately, or where there's a history, a past history of postpartum hemorrhage in the mother beforehand, we prepare adequately by providing carbetocin. This is what we use when maybe some of the people that are grand multiples, like we have patients, some of them are para 6, para 7, gravida 7, gravida 8. So we know that there might be some problem. So because of uterine atony, we provide carbetocin. Thank you.
Emilia, any comments?
No comments. I think it is very, very important to comment about what's the degree of implementation and what can be done in low and middle income countries for implementation of PBM programs. I tried to answer to our persons in the webinar that awareness of population, awareness of health workers, population knowledge about the importance of anemia, oral iron, if possible, during pregnancy, and nutrition. Those are programs that can be implemented quite easily if there is an awareness on that. I'd like your comments, Mauricio.
Yeah, I want to share a tool. Is the FIGO passport, passport from International Federation of Gynecology and Obstetrics. And it's very interesting because this tool, this passport, try to, at the end of the pregnancy, they put the women in all the aspects that you mentioned, Emilia, nutritional, and prepare the woman for the next pregnancy. And it is like a cycle. It's at the end of the pilar, the final pilar, the pilar 3, and then going again to the pilar 1. And I will share in the chat. The name is FIGO Passport. And it's interesting because with preconceptional care, we do a lot of work, especially in the low resource setting and the low and middle income countries.
Mm-hmm. What do you think, Elizabeth, about these kind of strategies from the field? Because Mauricio and me are speaking from different environments, and probably you will give us another view.
Yes, thank you very much, Emilia. Yes, I agree with you that these are very important strategies, and that these strategies, they have been on for quite a long time. Even way back when we were in medical school, there is this program where all women who enlist for antenatal care are giving talks on nutrition and diet, and it is the routine to give iron supplementation in pregnancy from the time of booking. Well, usually women are encouraged to book from the first trimester. So immediately it is documented that they are pregnant, iron supplementation is continued until the time of delivery, and after, even during the puerperium, it is continued even till a month or 2 months after delivery. So that has been an ongoing thing. And also nutrition health talks are given to pregnant women. And even before the pregnancy, it is a routine when people come to hospital that they are given this intervention. However, the difficulty might be for those that don't have access to the hospital or don't get to the hospital on time. Those are the areas that we may have some problems. So what we are doing now is public enlightenment. And this is being done in the schools, in primary schools, in secondary schools, in the universities, and also on the media, through the print media, on the social media platforms, on radio, on television. Talks are given on the importance of adequate nutrition, the types of food to eat. And, you know, in Africa, we're blessed with things like green leafy vegetables. We're blessed with a lot of fruits and vegetables that are rich in iron. So people are encouraged to take these types of food and to are taught, housewives and other people are taught the best way to prepare them, to cook it so that it doesn't lose the nutritional value. So yes, I agree with you. These are very important things, and they are low-hanging fruits that can easily be done, and we can easily reap the benefit of it because it's just out there for us to implement. So thank you very much for that.
There is a couple of questions that I think that we may have not given the clear message. One of them is the prophylactic use of tranexamic acid and the use of tranexamic acid in anemic patients. Both things are not related, and prophylactic use of tranexamic is not recommended yet. Do you have any comments on that, Mauricio or Elizabeth?
Yes. From a global perspective, we need to give some tools for the low and middle income countries and the low resource settings. And I mentioned before, there is a randomized control trial called the I'm Woman. Most of the people who assist to this webinar is participating in Nigeria, Tanzania, Pakistan, recruiting patients. But in the low resource settings and the low and middle income countries, in patients with the high risk of death by PPH, personally, I use 1 gram of tranexamic acid before the incisation on when the baby is crawling. If I work in the high income hospital, I know that they need more evidence or more safety data for doing that. But I repeat, for the low middle income countries and the low resource settings, that's my practice, and I share with you the way that I do it.
Elizabeth?
Okay. Yeah, Emilia, thank you for that question. It's very important that we realize that we have not started using prophylactic tranexamic acid as it is. We only give it when it is indicated. In my practice, we give it intraoperatively. Some obstetricians will not want you to give before their incision. So it also depends on the practice of the obstetrician, because we're not working alone, we're working in a team. So sometimes we wait after the baby is delivered and they are closing up. If they feel that they need to reduce bleeding, they request for the tranexamic acid, and we give 1 gram and in an infusion, and we let it run through over some minutes, and then as they close, they will usually, that is adequate to reduce any blood loss. But as for to give prophylactically, I think that in our practice, we will probably need more evidence to have that as an indication. Another thing we have to realize is that tranexamic acid is not available in all the centers. It's usually mostly in the tertiary hospitals, like the big university teaching hospitals or the specialist hospitals or referral centers. So that is another issue that we need to address. So maybe we need to do some more research and find out if there is a difference between giving prophylactically and giving as per when indicated, when there are signs that there's excessive bleeding and you want to prevent it or stop it. Thank you very much.
Just if we have time, I'd like to add any comment on general anesthesia, that it's another question, general anesthesia or regional anesthesia in this kind of patients. I think it is important to highlight that general anesthesia is the first choice if the patient has hemodynamic instability or if she develops hemodynamic instability, despite we have a perfectly working spinal or epidural anesthesia. The best way to protect physiology in a bleeding patient is general anesthesia with endotracheal intubation. Any comment from Mauricio or Elizabeth?
If no contraindication, try to do an regional anesthesia, spinal. But as you mentioned, general anesthesia is fully agree with your comments. Yeah.
Yes, thank you very much, Emilia. I agree with your comments. If there is any hemodynamic compromise, general anesthesia is the good way to go. But sometimes we do have some limitations in terms of not having all the facilities that we need for to upscale to a full-blown general anesthesia with endotracheal intubation and all that. But that is certainly the safest way to go. What we do in my practice, generally, we try to start with a spinal if it is not contraindicated. But if we have any contraindications or, like you said, hemodynamic instability, and we cannot optimize the patient prior to the induction of anesthesia, then of course we go for the general anesthesia. Thank you.
Mauricio?
Emilia, I think that we are on time. Yes. Okay. Oh,
There are some questions in the chat, I think, and some comments also.
yeah. Rosa, if maybe if you can send us the questions.
Yes, I can do that, and you can answer them later.
Yeah, because we are on time, Elizabeth. Okay. Thank you very much for stay here around the globe. We have people from around the globe. And Elizabeth, thank you so much for being so inspiring and help us and give the what we need to work in the low resource settings and the low and the middle income countries. That is very important because 80% of the people don't have fancy hospitals and they have a lot of drugs, and that's very important to that approach to the low resource settings. And I want to pass the word to Emilia for the closing remarks. Emilia?
Yes, thank you very much, Mauricio, Elizabeth, Rosa, for your continued support. And I want to say to all the audience that we have the same problems in high-income countries, Anemic patients come all the time to our operating theaters and delivery suites. So it's not only a low middle income countries problem. We have to invest on that. And if we have saved just one life today, it is good.
Thank you so much. Bye-bye.
you.
Bye.
Bye, Emilia. Bye, Elizabeth. Rosa, thank you so much.
Opportunity. Bye.
Thank you all. Bye bye.
Bye.